Lisa Marchiano is a writer and Jungian analyst in private practice in Philadelphia. She's worked with parents of gender dysphoric youth, gender dysphoric and trans-identified young adults, and detransitioners. Her writings on gender have appeared in Quillette and Psychological Perspectives. She has contributed chapters to several books on the topic of gender and has presented nationally and internationally on the subject. Lisa is a co-host of a popular podcast, This Jungian Life, and teaches at the Carl Gustav Jung Institute of Philadelphia. Her book, Motherhood, Facing and Finding Yourself, will be published by Sounds True in May 2021. I first came across Lisa in the book, Inventing the Transgender Child, the paper that she wrote there, which she and I have had some discussion about. An excellent paper. Okay, I'll hand over to you now, Lisa.
The title of my talk is On Reality and the Affirmative Model of Care. And I'm going to be talking about reality because reality is really important to what I do. I'm a psychotherapist. And really, what do therapists do? Well, we help people adapt. We help people adapt to outer reality. And if we have a depth perspective, we help people adapt to inner realities. And so what happens when therapists abandon reality? That's what I want to talk about. The dictionary tells me that reality is the state of things as they actually exist, as opposed to an idealistic or notional idea of them. The psychologist Robert J. Lifton, who's well known for his work with cults, has pointed out that what we call reality actually has two different aspects. One part refers to what is socially constructed and agreed upon in society. For example, we believe that children are not fully capable adults until they're 18. This kind of reality can change or be renegotiated. But there are also, and this is a quote from Lifton, immediate factual components of reality which in no way depend on theoretical constructions. When someone has a break with immediate factual reality, this person might have delusions or hallucinations, and we would consider her to be psychotic, an extreme state of mental unwellness. According to Lifton, we require a shared sense of reality consistent with experience and evidence for our collective function in a democracy. So what happens when we lose this shared sense of reality? And I'm particularly interested in what effect this has on us psychologically. And my rather obvious thesis is that it does not lead us toward greater psychological health. Becoming unmoored from reality impedes our ability to function and to navigate the world in the most fundamental way. The effects of cutting ourselves off from reality are both blunt and subtle, immediate and long-term. And I'm going to be addressing this today with reference to a case of a young detransitioned woman I have worked with. But first, I'd like to share a mother's story. The mother of a 13-year-old girl who suddenly declared a transgender identity followed the recommendations of therapists, as well as the common wisdom offered in the media and among her peer group in her liberal, well-educated neighborhood. She changed her child's name and pronouns, bought the girl a binder and a new wardrobe, and began adjusting to life as the mother of a transgender boy. Though she did so with the support of friends, family, and a new community of other parents of trans-identifying kids, she mysteriously developed severe vertigo. Whereas she used to take daily walks with friends, she now found she was unable to do so. At times, she experienced a disturbing sense of disorientation. I suddenly couldn't understand how trees worked, she told me. I couldn't make sense of how they stretched toward the sky, yet their roots were able to hold them down. She described her malady as a sense of groundlessness. Her dizziness was severe enough that she now needed to be accompanied when she walked the family dog. The symptoms continued until she read Irreversible Damage by Abigail Shrier. Within a few days, after a battery of medical tests, The mother realized that there was no organic cause for her vertigo. Rather, her dizziness was a somatic, symbolic symptom that evidenced the profound disorientation she experienced as she attempted to deny reality. Now, I'd like to discuss the case of a detransitioned young woman. I am sharing her material with her permission, and I have disguised identifying details. Maya's story. Maya began working with me at the age of 22. Her parents were educated professionals. According to Maya, it was a standing joke in her home that her mother, Elena, was not cut out for motherhood. She had precipitously ended her maternity leave just 2 weeks after Maya's birth to return to her demanding job, sending for an aunt to come and take care of the baby. Aunt Mary had an apartment above the garage, and Maya remembers her as warm and loving. Maya loved Mary's cooking and often slept with her because she was afraid to sleep alone. Both parents were absorbed in their careers, and Maya's memories of them are few, except for the stilted family meals her mother scheduled a couple of times during the week. Elena did take an interest in Maya's dance lessons, but Aunt Mary provided daily care. When Maya was 9, Aunt Mary suddenly died. Maya was not allowed to attend the funeral, as her parents felt that it was better if Maya didn't dwell on the loss, and they encouraged her to move on. A succession of babysitters quickly replaced Aunt Mary, and life went on as usual. Maya had maintained a strong connection to her dance squad peers until age 12. She had difficulty with the transition to middle school, and pubertal changes caused significant breast development. She dropped out of dance. Slender, small-boned Elena, concerned about Maya's rounding body, encouraged dieting. Maya discovered she could binge and purge. She also started to struggle in school and acquired a reputation as a problem student. Deficits in parental attention and the loss of Aunt Mary were augmented by physical and school changes and the absence of emotional support at home. Feeling outcast and unworthy, Maya isolated and spent more and more time online. Maya's time on social media fed a rumination about identity. When she shared with some of her online friends that she wondered whether she might be trans because she felt uncomfortable in her body, her friends on social media were quick to affirm and celebrate her. Maya cut her hair boyishly short and began wearing oversized jeans and sweatshirts. In her online life, she adopted a male name, Archer. At 14, Maya announced to her mother that she was trans and wanted to see a gender therapist so that she could start hormones. Although she was at first dismissive, Elena eventually went with her to speak with the school psychologist. Even Maya was surprised by how quickly the psychologist agreed to call her Archer and confirmed her trans identity. The psychologist concurred with Maya that Elena's reluctance to approve hormone treatment was harmful and encouraged Elena to affirm Maya's identity as male and support medical transition. Maya's parents did not allow her to begin hormone treatment. They were preoccupied with work, and Maya was left to navigate this tumultuous time mostly on her own. Maternal attention often came as criticism of Maya's refusal to conform to expectations about appearance and traditional femininity. Elena placed a high value on cultural norms for feminine beauty, her figure, makeup, fashionable clothes, and heels. Elena had taken pride in the elaborate outfits required for Maya's childhood dance performances. She liked to dress me up, Maya recalled. Elena found Maya's masculine presentation enraging. Maya was no longer the adorable daughter who could serve as a narcissistic extension for Elena. Shortly after her 18th birthday, and now a freshman in college, Maya visited an informed consent clinic. She was given a prescription for testosterone after a 30-minute meeting with a nurse. Starting testosterone initially made her euphoric. However, Maya recalls the period during which she took testosterone as difficult and disorienting. She became easily enraged and isolated herself in her dorm. Because she rarely attended class and was preoccupied with matters other than academics, Her grades were poor. She dropped out of college at the beginning of her sophomore year. Maya's mental health had deteriorated, possibly due in part to testosterone. She recalls being an anxious, angry mess and experienced intense self-destructive moods. She was hospitalized twice for suicidal ideation. Eventually, Maya stopped testosterone because she suspected that the hormone was contributing to her worsening mental health. Shortly after that, she began the process of re-identifying as female and began treatment with me soon after. Capitulating on reality. According to Ronald Fairbairn, the traumatized child interjects an idealized parent and a persecutory or absent parent and relates to them out of two corresponding self states. For Maya, relating to the idealized mother offered the illusory promise of love and care, but required her to sacrifice relational truth. She had to pretend she didn't know what she knew. Maya recalls trying to tell other adults about her mother's indifference and coldness and always being reassured that Elena loved her. This is the bargain she had made repeatedly in the past, that the truth would be sacrificed in exchange for the hope of love and attention. We came to see that a similar dynamic had been at work during her trans identification. Maya had sacrificed the truth of her knowledge about her biology in exchange for belonging and connection in the trans community. As the dynamics with her mother came into focus in our work, we had a clear understanding of the defensive function of Maya's trans identity, which served multiple unconscious goals. Rejecting her femaleness was a way of rejecting her mother while asserting her independence and defiance of her mother's expectations. This allowed Maya to disavow her desire to be like her mother and be loved and admired by her, while also allowing her to be the obedient child by abiding by the unwritten rule that she must never surpass her mother. It was a way to opt out of her mother's paradigm of feminine attractiveness, and it gave Maya a way to identify with the aggressor by acting out the wrongness of her body. Just as her mother imposed restrictive dieting regimes on Maya's growing body to change it and make it conform to her arbitrary expectations, Maya imposed testosterone and binding her breasts to change her body and make it conform to her arbitrary expectations. Identifying as trans also shifted the power dynamic in Maya's relationship with Elena, allowing her to claim some aggression and authority. When Maya tried to speak about her difficulties with her mother as a child, her concerns were often dismissed or minimized. Now, as the righteous, beleaguered victim of her mother's bigotry, adults and peers agreed loudly that Maya's mother was deficient. As a trans man, Maya's complaints about her mother were valorized and amplified by the school psychologist and peers on the internet. The gender affirmative approach. When Maya sought therapy from the school psychologist, she was evidently treated according to the gender affirmative model of care. The therapist affirmed that Maya was a boy and that she needed to transition socially and medically. The gender affirmative model of care was first developed in the US and has become the dominant way of working with trans-identified teens in many contexts in the US and elsewhere. Psychologist Diane Ehrensaft defines the gender affirmative model as a method of therapeutic care that includes allowing children to speak for themselves about their self-experienced gender identity and expressions, and providing support for them to evolve into their authentic gender selves, no matter at what age. Interventions include social transition from one gender to another and/or evolving gender nonconforming expressions and presentations, as well as later gender-affirming medical interventions, puberty blockers, cross-sex hormones, and surgeries. To facilitate this process, the therapist assesses a child's gender, according to Ehrensaft, using assessment instruments, observations, play, interviewing dialogue, or projective measures. Diane Ehrensaft sums up the gender affirmative approach in the following manner. When it comes to knowing a child's gender, it is not for us to tell, but for the child to say. The affirmative model takes at face value a child or teen's declaration about feelings and thoughts related to gender. It encourages parents, schools, and other authorities in the child's life to accept those claims. Though this approach has gained widespread acceptance, it has significant shortcomings. It may foreclose thinking about a young person's development by conflating gender dysphoria with trans identification, and it may concretize an adolescent's desire to transition without extended exploration and assessment. Because the basic premise of the model is that gender is something for the child to say, unconscious relational, systemic, archetypal, and social factors are denied relevance and exploration. Maya's trans identification was an attempt to adapt to a complex array of interrelated factors: her social environment at school and online, the dynamic between her and her parents, her rejection of her body, inculcated in part by her mother's insistence on thinness and dieting, and her unmetabolized grief about the loss of a primary attachment figure early in life. Affirmative treatment addressed the superficial distress, but left little room to explore other factors. So psychological work in these important areas did not take place until after her detransition. The gender affirmative model of care may leave some or all of these psychological factors unaddressed, because one of its basic tenets is that the role of the therapist is to affirm or confirm what the patient knows. This principle is in direct opposition to usual and best psychotherapeutic practices. The role of the therapist is to open space for exploration, more nuanced thinking, and expanded and deepened self-understanding. For Maya, the affirmative approach appears to have supported a narrow and superficial understanding of the presenting problem. She was encouraged to believe that physical interventions would resolve her psychic pain, thereby substituting the possibility of legitimate and potentially transformative suffering for a concretized solution that promoted dissociation from the body. Reality. The gender affirmative model of care rests on a false premise and encourages the patient to make critical health decisions based on a belief that contradicts material reality. The model presumes the existence of gender identity and privileges it over a child's embodied reality. Human sex is binary and cannot be changed. Gender identity is not a well-defined concept and lacks empirical validity. Although there have been efforts to identify biomarkers that might correlate with gender dysphoria, no robust evidence has been found. The UK's Gender Identity Development Service, for example, has noted the chromosomal normality of their patients. Although the phrase born in the wrong body is sometimes used to describe the experience of gender incongruence, this is at best a metaphor, not an empirical fact. Affirmative clinicians themselves acknowledge the lack of material basis for gender identity. According to advocates of the affirmative approach, and this is a quote, "We understand gender identity, both its match and its mismatch with assigned natal sex, as primarily informed by a child's cognitions and emotions rather than by genitalia and observable external sex characteristics." The affirmative approach then privileges a child or young person's thoughts and feelings about herself, even when those thoughts and feelings are in direct opposition to the material reality of the body. Murky language and definitions at the outset render downstream discussion confusing, if not impossible. This is another quote: "Gender identity has to do with what gender you are." This definition of gender identity is tautological and no definition of gender is offered. Because it is based purely on subjective criteria, the assertion that one has an internal sense of gender identity amounts to an unfalsifiable statement of belief. Without a basis in biological reality, gender identity takes on the significance of an essence, something akin to a soul. Gender identity, we are told, is a person's inner sense of being a man, a woman, or something else. Whether we believe in the existence of an immortal soul or find it a worthy metaphor for describing experience, we recognize the value of the concept. As a metaphor, the notion of gender identity invites questions about our nature, our relationship with culture, and our relationship with the inner other. It may be the best possible way to express an ineffable truth, but we do not treat soul as an empirical fact. We do not base laws or invasive medical treatments on its existence, unlike gender identity, which is treated as empirical reality in some areas of law and clinical practice. When gender identity is taken as empirical fact, the metaphor becomes concretized. We lose the ability to relate to our inner world in a symbolic way and therefore impose interventions on the physical body. When metaphors are made literal, then the literal body becomes a vehicle for metaphoric expression. What, according to the affirmative model of care, are we meant to affirm? We can validate a young person's discomfort with restrictive gender roles. We can celebrate her desire to flout conventional gender norms and to wear clothes or hairstyles that defy gendered expectations. We can affirm and normalize feelings of same-sex attraction and help her to come to terms with these in a society where homosexuality is not always accepted. We can validate a young person's distress about the perceived mismatch between her sense of herself and her body. We can affirm the importance of these feelings and the distress that they cause, and we can even respect her need to live in the opposite sex role as a potential way to manage this distress. But in practice, affirmation goes further than this, affirming a patient's belief in the inaccurate idea that she has an innate male gender identity. In this case, are we colluding with the avoidance of reality? Confirming a young person's false belief puts her at odds with her body, her biological reality, and places her at an adaptive disadvantage. Jung stressed that adequate adaptation requires that we be able to grow in the soil in which we are planted before further psychological growth can proceed. Adaptation requires confrontation and acceptance of the realities in which we find ourselves. We do not help our clients by encouraging them to cling to illusions. Livia, a 23-year-old detransition woman who had a mastectomy and hysterectomy when she was 20 and 21 respectively, spoke at the Detransition Advocacy Network event in Manchester, UK in 2019. She emphasized the role of reality in her transition and detransition. And this is part of Livia's testimony that I'm going to read. She said in the beginning, "It's really hard to focus on one thing, but the word that's stuck in my mind the most is reality. I feel like for me, transition was a way to get out of my reality as a homosexual woman." Later in the presentation, Livia speaks again and says, "When we started this conversation, the word that was important to me was reality. And reality to me is that a hysterectomy and removal of your ovaries doesn't make you any less female. So it doesn't make any sense to me why this is called transition or a sex change, because it's not, it's castration. And now that I am trying to care for my health as much as possible, I spend a lot of time on hysterectomy support sites and message boards for women. For women, because only women get hysterectomies and only women deal with the consequences of a hysterectomy. Affirmative care for teens may reify defenses against reality, in the words of Alessandra Lemma. Life's task, as well as the task of analysis, is to come to terms with that which cannot be changed and to mourn this so that we may move forward. The reality of our bodies insists on being confronted and acceptance in adolescence. This task can be particularly challenging for adolescent females. Social and medical transition undertaken without adequate understanding may facilitate and this is Alessandra Lemma, a bypassing of a mourning process about that which cannot be changed. Coming to terms with bodily reality is a major task in adolescence. It is a time when we learn what our adult body will look like. The inexorable reality of our bodies is, for many of us, the first demand to face limitations, a painful prerequisite for coming into existence in three-dimensional space and time. Jung understood the great importance of coming to terms with reality, and in particular, the reality of our bodies as regards the task of lifelong psychological growth. And this is Jung. He said, if you were a spirit, you could be anywhere, but the damnable fact is that you are rooted just here and you cannot jump out of your skin. You have definite necessities. You cannot get away from the fact of your sex, for instance, or of the color of your eyes, or the health or sickness of your body, your physical endurance. Those are definite facts which make you an individual, a self that is just yourself and nobody else. If you were a spirit, you could exchange your form every minute for another one. But being in the body, you are caught. Therefore, the body is such an awkward thing. It is a definite nuisance. All people who claim to be spiritual try to get away from the fact of the body. They want to destroy it in order to be something imaginary. But they will never be that because the body denies them. The body says otherwise. They think they can live without sex or feeding, without the ordinary human conditions, and it is a mistake, a lie, and the body denies their convictions. Puberty blockers, cross-sex hormones, and surgery are Promethean efforts to subdue biological reality. We defy the body at a cost. The longer-term psychological and physical impact of medical interventions is not well understood, and such interventions create only the appearance of the opposite sex. No one can actually change sex. As Jung says, we must acknowledge the realities of embodiment. Reality and trauma. Psychological trauma warps our sense of reality, rendering us unable to trust our senses. Helping a client to reclaim her relationship with reality can be an important aspect of trauma work. Maya's grief over the loss of her aunt was denied, and she was encouraged to move on as though that relationship were insignificant. The reality of her relationship with her parents was also not mirrored back to her. This rupture in her sense of reality made it difficult for her to make meaning out of her situation and contributed to poor affect regulation, as she was always confused about the nature and location of the problem. When Maya detransitioned and reaffirmed her biological reality, her distress decreased and she felt somewhat more contained. As she reconnected with reality in her relationships, her sense of coherence and psychic equilibrium increased. Even though reality was distressing, having a firm grasp on truth gave her greater resilience. The case of Maya illustrates the extent to which a presenting problem was a metaphor for unresolved grief and deficient parenting that was later exacerbated by peer and professional wounding. The purpose of psychological treatment is to bring unconscious issues to consciousness, thereby recovering and reconnecting affect, cognition, and reality. Depth psychology posits the active presence of unconscious compensation and symbolization processes. The mythos of gender identity. If we think of a belief in gender identity as a kind of neurotic fantasy, then, and this is a formulation of Brett Alderman, a depth-oriented psychologist, we might also imagine a hidden treasure within it, something potentially curative and redemptive. What is the symptom trying to cure or compensate in the collective? The affirmative model of care concretizes psychic pain, locates it in the body, and seeks biomedical treatments for it. Paradoxically, it also offers a compensatory belief in a disembodied, ineffable essence. In a BBC documentary, transgender psychotherapist Herschel Russell relates the story of a mom who asked her 8-year-old gender diverse child how he knew he was really a boy. According to Russell, the child responded, "I know way down deep where the music plays." With the continued decline of traditional religious beliefs, are we unconsciously seeking a new way to conceptualize spirit? And does gender as a mysterious disembodied imperative offer us this? The mythos that informs affirmative care allows us to see ourselves as beings with an existence that transcends our mere corporeal form. Jung famously remarked that the gods have become diseases. Gender identity ideology may be an unconscious attempt to find the divine hidden within the disease. We are perhaps being asked to find anew a connection with that which is non-rational and transcends materiality. If this is the corrective offered by gender identity ideology, we would do well to allow ourselves to be informed by this impulse while also maintaining contact with embodied reality. Thank you.
Sue's a psychoanalytic psychotherapist who originally trained as a general, then a psychiatric nurse, and she worked for nearly 40 years in the NHS in a variety of settings, including the DRID service of the Tavistock. She's now in private practice in South East London. She's a member of the British Psychotherapy Foundation and the London Psychoanalytic Psychotherapy Service. Sue was the original complainant with Mrs. A, the anonymous complainant in the Judicial Review, before handing over to Kira Bell, but remained a witness in the case. Marcus is a psychoanalyst. He worked as a nurse in mental health services and an adult psychotherapist in the health service for many years, 40 years. For several years, he was clinical lead in the adult and adolescent department at the Tavistock and head of nursing for the Trust. He is the author of Making Room for Madness in Mental Health and Psychoanalytic Thinking in Mental Health Settings. He resigned as governor from the Tavistock Board of Governors over the management of JIDS in February 2019, and also acted as a witness in the case.
In fact, I'm just about to address one of the questions that I've seen in the chat from somebody named Jordan, who asked...
Oh, good. I was going to ask you that. Great.
So, who asked about whether we feel that transition is ever right. So I'll come to that straight away. It was the beginning of our talk, actually. So although we do argue against the transition of children before maturity, as therapists, we are neither for or against the adult's choice to transition, because we understand that to transition is, for some people, the best way to lead their lives and present to the world. So the model we're going to talk about shortly provides a process of psychological exploration in which the individual's personality structures, beliefs, defenses, and motivations are examined in a supportive environment, which we believe is helpful for anybody planning on such a life-altering decision. So between 2003 and 2007, as you said, I worked at the Gender Identity Development Service, which I'll now call JIDS from now on in the presentation. And for children, this was at the Tavistock Clinic. I became concerned about some of the children being referred after very few appointments for hormone treatments. But any attempts to discuss this with the team, I felt met with a superficial reluctance on their part to examine things. It seemed like a clinical service where some of the staff did not explore in any meaningful way the presentation of their patients. With my concerns growing, I decided to speak to the Trust Medical Director. An internal inquiry did take place in 2005 to 6, and that made recommendations that the service should carry out more rigorous investigation and research in the area. But as we all know, nothing really changed. And eventually I resigned from the clinic. I continued to work elsewhere in the Tavistock Trust and was very proud to do so at that time. In the autumn of 2018, Marcus was elected as a governor on the board at the Tavistock Trust. He became aware of two issues. The first was a letter from a group of concerned parents regarding the quality of the treatment their children had received at the Gender Identity Clinic. The second was David Bell's report, where about 10 staff, I believe, Dave, contacted you as a staff governor over serious safeguarding concerns. So Marcus resigned in February 2019 because he did not believe the Trust intended to take seriously the concerns raised, and he tried very hard with the board. Several things followed, one of which was an event named Duty of Care, First Do No Harm, the Ethics of Transgender Healthcare, which was run by Standing for Women and hosted by Dr. Lord Lewis Mooney at the House of Lords. I attended, and the guest presentations were deeply concerning. After the event, as is often the case, several of the participants reconvened to the local pub. Discussions took place on how to tackle the apparent disinterest from the National Health Service to ensure that clinical safeguarding and ethical practice were occurring in the area of gender medicine. One problem we came across was a serious reluctance at that time for most professionals to speak out publicly on this matter, and journalists who contacted us after the story broke said they couldn't really find anyone to go on the record. A small group of us agreed that the evidence for this experimental treatment needed to be rigorously and independently examined, because meanwhile, the Tavistock and the NHS in England were continuing to publicly deny there was anything to be concerned about, despite, as we have now learned from a programme that our BBC did on its Newsnight investigation, the fact that the Tavistock internal report actually had many GID staff expressing similar concerns about safeguarding. Because of the publicity, Marcus and I were being contacted by parents and ex-patients with upsetting, sometimes absolutely harrowing treatment experiences. They were extremely grateful and thankful and relieved that finally some professionals were speaking out about this treatment model. One of the parents was Mrs. A, the mother of a 15-year-old daughter who had been experiencing emotional difficulties. She also had a diagnosis of autism, and she had then decided she was transgender. She was on the waiting list for the Gender Identity Service, and after hearing the various reports in the media, Mrs. and Mr. A were deeply worried that due to her age, their daughter would be started on hormone treatments without a thorough psychological assessment and treatment. As I said, the Tavistock seemed unable to examine themselves, and whilst I agree with the earlier presenters who said the law isn't the only turn to make, it was just, we felt that there was nowhere to go with it. So following a consultation with the legal team, Mrs. A and I agreed we should request a judicial review on whether children can indeed give informed consent to hormone blockers. In October 2019, we applied to the High Court and it was accepted. We then started gathering a multinational group of expert witnesses, one of whom was Kira Bell. Kira, now a detransitioner, believed that at the age of 15, her comorbid difficulties had not been sufficiently assessed or treated at GIDS before she was started on blockers and cross-sex hormones. Move on to January 2020, our evidence was submitted at the Royal Court of Justice in London for the judicial review. Then in February 2020, Kira substituted me in the case and joined Mrs. A as the co-claimant. October 2020, the judicial review took place with 3 judges at the High Court. And in December, just last year, they ruled against the defendants from the Tavistock. And I believe we're going to hear more about that verdict later, Dave, so I won't go into that now. So once I knew there was an upcoming judicial review which might prevent gender dysphoric children from being treated with puberty blockers, we agreed that we needed to contribute something which might help the children, their parents, and the professionals now caring for them. Hence, we started writing our book, which is due to be published hopefully in the spring sometime. And we're now going to talk briefly about some of the ideas. So a wish to transition is often described by individuals as a belief they were born in the wrong body and consequently deprived of an ideal. The ideal is the self that would either be loved and accepted by others or be loved by themselves. In this ideal state, the individual would be free of the usual sorts of mental pain, conflicts, and humiliations. We wish to re-emphasize the importance of not separating gender dysphoria from any other aspects of a person's mental functioning. Many of the young people presenting with gender incongruence have comorbid problems, as already discussed, such as depression, eating disorders, PTSD, and also many of them have autism, approximately, we think 30%, although we don't know exactly. The denial of the psychological factors influencing the desire to transition can unwittingly lead the patient and the service to look towards more concrete, affirmative solutions, whilst omitting important consideration of the individual's mental health and any potential link between their underlying condition and their gender dysphoria. Marcus is now going to talk about a few of the theoretical ideas that we've written about.
So many children who are drawn to the idea of transition have got a fragile ego that threatens to fragment when overwhelmed by psychic pain. The trans-identifying adolescent looks to cure this and starts to become more fixed on a very narrow field of mental life, in the belief that if only I could transition, my problems would resolve and everything would be all right. Individuals with fragile ego structures are also prone to black and white thinking that looks for concrete rather than symbolic solutions. All the above makes them very susceptible to the rigid thinking and stereotypes found in much of the trans ideology. We've found the desire to transition is often related to a wish to control sexual development, perhaps put a lid on it. And many detransitioners say there's very little talk about sex on the pro-transition websites or in the medical care they receive. Hence, perhaps, with the current affirmative model of treatment, services are often providing reassurance to young people that anxieties about sexual development can be removed by gender transition. We would argue that the adolescent confusion and distress is a normal and necessary part of development. And over time, the adolescent can be helped and supported to become an adult who can enjoy their natal sexual body has to offer. However, a defensive structure that puts a lid on development appeals to children who feel threatened by the demands of and confusions brought about by sexual development. With the use of puberty blockers, transition may be seen as a way of stopping and controlling these anxieties. Gender incongruence between mind and body. When a person states they're trans or reports gender dysphoria, it's important to listen to and explore what's occurring for the individual. The presentation and message from a patient can be very fixed and one-dimensional. Rather than the patient presenting a distressing psychological symptom, they're more usually talk of a feeling of detachment or discomfort with the body they were born in. That is felt to contain unwanted aspects of the self, represented, for example, in boys by their Adam's apple, hairy legs, and in girls by their breasts and menstruation. The unaddressed problem, however, that although medical interventions may interfere with the body and block its sexual development or functioning, they can't completely eradicate the patient's natal gender. This might lead to a sense of persecution, as the body's a constant reminder of the continued existence of unwanted aspects of the self. And as Lisa said, reality. It's a reminder of reality. This persecution is often projected into others, whose position of neutrality and or curiosity is experienced as forcing doubt into them, and thus undermining their belief in transition as the solution to their psychological problems. This persecution is also apparent in extreme reactions to mispronouncing or dead naming, or other external reminders of the natal body, such as a member of the public misgendering an individual. Patients often put enormous pressure on families, schools, and clinical services to join with them in the belief that transition to the ideal body is the only solution to their problems. When the family or clinical service accept without sufficient questioning the individual's assessment of the problem as being their natal sex, they're supporting the patient's belief that the psychic problem can be dealt with by interfering with the body's appearance and functioning. The wish to remove pain. Families and services may feel they're being humane by trying to alleviate the individual's distressing symptoms or gender dysphoria with affirmation. but there's evidence that supporting the individual's wish to transition can exacerbate rather than alleviate psychic distress and perpetuate the feeling that the natal sex is unacceptable. Clinicians come under intense pressure to agree with the patient's diagnosis. Staff want to protect the patient from an unnecessary pain and anxiety. However, pain and anxiety often provide an indication of an underlying problem that needs attention. Long-term problems arise when clinical staff feel forced into providing a quick solution to a patient's distress before examining the underlying causes. The role of defensive structure. The fact is that human beings are complicated. Our problems are multidimensional. Therefore, any solution usually involves separating things out and looking at issues from different points of view. The therapist needs to take an interest in the meaning of the patient's presentation, as well as exploring the dynamics underlying the presentation and the systems, the belief systems. However, any exploratory stance, as I said before, can be experienced as very disturbing or offensive. This is because it threatens to undermine the internal defenses and beliefs which they're relying upon to protect them from overwhelming feelings of anxiety and guilt. The therapist needs to understand the role the defensive structure plays in supporting the ego and managing anxiety before pointing out the costs of the defenses. Fixed states of mind. Two of the current diagnostic criteria for gender dysphoria are the demonstration of persistence and consistence in their gender identity. But we strongly question the value of these diagnostic symptoms when forming a care plan for a young person. Many young people with gender dysphoria appear to be frozen in their current preoccupations, with any natural doubts and anxieties about their wishes for transition absent and projected into those around them. For example, it's often argued by gender services that the child was certain they wanted to transition, as if this is a sign of psychological health. Whereas we would view this as evidence of a disturbed state of mind in which appropriate anxieties about the cost and pain of transition are being projected into others or disowned in an attempt to stop the confusion and the psychological turbulence that appropriately accompany developmental conflicts. In our experience, we found that children wishing to transition often hope that a parental figure will help to identify and understand the part of the self they're trying to discard. Some detransitioners mention they were disappointed by the professionals' inability to stand up to their insistent demands. The splitting off of sexuality. Children and adolescents have all sorts of fantasies and anxieties about the mechanics of sex and sexual roles. These desires and conflicts touch on infantile fears of being invaded or invading, being overpowered or being powerful. Transition involves placing a block on the development of sexuality. When working with gender questioning patients, talk about sex and sexual fantasy has to be carefully managed and age appropriate. But it's essential to explore the person's fears and fantasies about sex and sexual orientation. Understanding these areas of difficulty might avoid altogether the need for medical treatment such as hormone blockers, which are designed to prevent the development of sexual characteristics. It's easy to understand why a young person who's in a tremendous conflict with regard to their sexual development might report improvements in their feelings, distress or dysphoria, because any sexual development is a threat. But people need to be helped to come to terms with their sexual selves, and therefore, rather than joining the anxious adolescent in the belief that the whole area should be avoided or stopped, it's helpful if the therapist can support the person to begin to think about these fears and anxieties, because adolescence is this developmental process towards adulthood. which is a difficult one. Split states of mind. Although the young person may maintain a belief they need to transition, this may not have been thought about in relation to the loss or costs of transition. The therapist attempting to bring in these different aspects of the patient's personality can often be represented through the patient's wish to change names or change schools. While conflicts with the young person over what they're called may be unproductive, the therapist must keep in mind that the natal sex and identity of the individual, for example, if a child wants to change their name from Joanne to John, the therapist should keep in mind who Joanne is, why she's so unwanted, so unacceptable. Attempts to eradicate unwanted aspects of the self are common, but it's not really possible, as discarded parts of the self tend to re-emerge, particularly when we're under pressure. Mental health is based on an ability to integrate various aspects of the self while differentiating between psychotic and non-psychotic forms of thought. We might not be able to entirely eradicate our omnipotent fantasies, but it's helpful if one can recognize the difference between reality-based thought and wishful thinking. Many detransitions report that at some more hidden level of the mind, they knew they had doubts that might contradict their beliefs and ideas about transition, a kind of double bookkeeping. But the reflections show they needed professionals to help them address this split. And this is part of the difficult therapeutic task. The movement between fluid and rigid states of mind. In our clinical experience, the young person goes through often long phases of maintaining their fixed beliefs, while occasionally opening up and exploring their feelings in therapy. But this is usually followed by a retreat back into a fixed state of mind. At these times, the therapist needs to be supported in spotting these moments of life outside the retreat. The grievances in relation to parental figures will emerge in the transference relationship. The therapist will be asked to tolerate quite a bit of provocation as their work with the individuals continually attacked, undermined by parts of the patient's mind determined to keep a grip on the current defensive solution. It's helpful if the therapist can see the hatred or anger involved in these attacks is a developmental process. We need to appreciate them as evidence of the young person's desperate wish to keep their defensive structure. How am I doing for time?
That's fine, keep going.
Grievances.
About another 5 minutes or so.
Okay. I might skip the next bit.
It's
all right.
Yeah, well, okay, no, that's fine, that's fine.
Grievances towards parents. Most of us harbour grievances towards our parents for failing to provide us with the ideal mind, body, or environment. These grievances are often based on the belief that we would have been much better positioned to deal with life if only our parents had not, for example, favoured our younger siblings, given us smaller ears. Grievances towards parents who bequeath their genetic inheritance and so fail to provide their child with the ideal self that could master painful psychic states need to be explored and understood. Indeed, there are often conflicts over the use of names and extreme sensitivities to dead naming, etc. Changing the name chosen by the parents could represent an unconscious complaint against them, but not only gave the child the wrong body, but also gave them the name that gave them the wrong name. Many are afraid they'll lose their relationship with the child. Parents often afraid of taking up these grievances because they're afraid it will damage their relationship with the child. And that this oft-quoted statement, what would you prefer, a live trans kid or a dead child? Suicidal ideation. The threat of suicide can be a way of putting pressure on services and therapists to agree to medical interventions. However, the threat also contains a psychological truth as the individual believes they can't live with the unwanted aspects of themselves represented by their natal body and urgently need to eradicate them. Perhaps the suicidal ideation is connected to a wish to kill off a vulnerable aspect of themselves they feel they hate. However, in fantasy, the individual often believes the suicidal act will restore the ideal relationship or position they felt they've lost. Some part of the suicidal patient believes they'll survive and be reborn in some ideal way. In many ways, the therapist must find a means of relating that avoids pointless confrontations without colluding in an unhelpful manner. Indeed, we take the view that people might change their name, but they can't get rid of who they are. You can perform surgery on the body, but you can't surgically remove a part of your personality. Psychological maturity and mental health are based on the ability to tolerate different aspects of the self. As part of any assessment consultation, then, it's helpful to understand what the problem were that the name the person was given with, and what is their fantasy about transition. How's it going to help? Susan.
So just to conclude, really, as you said, there's a huge need for a thorough general assessment of any child who's presenting in a clinic, wherever that might be, to establish a picture of the person's personality, family dynamics, cognitive deficits as they may be, possible psychiatric disorders, and so on. Then an extended psychodynamic approach should assess and attempt to understand the meaning of the patient's presentation. Importantly, as we've said, this includes an understanding of the family and social context in which the gender incongruence has emerged. It involves an appreciation for the less conscious factors that underlie gender identity. This difficult psychological work can feel threatening as it challenges the individual's often strongly held conviction that only the change in identity can bring them relief. The fantasy that the body can be changed and sculpted as a way of being rid of profound psychological problems needs to come under closer scrutiny in the medical and therapeutic worlds. There is a great reluctance even to consider that the difficulties can be understood, at least sometimes through the lens of body dysmorphia, where the individual becomes obsessed with a perceived physical flaw. Plastic surgeons are very familiar with patients who seek surgeries in order to erase or manage a psychological difficulty, and the ethical among them refer these patients to psychiatrists. But rapid medical and surgical interventions for those with gender dysphoria will leave any of these underlying problems completely unaddressed and perhaps compounded. Children need help and support in coming to terms with who they are as part of the maturational process. Arguments made about encouraging the young person to discover their authentic self and demanding the right to puberty blockers deny the necessary dynamic and changing nature of human development. Young people's identity and their sexual attractions have the potential to change as they mature. So after the court ruling in the UK, some parents complained that their children were distraught, even suicidal at the thought of puberty. And patients often say they believe they will be more comfortable, it's a word I hear a lot, in their chosen gender identity. And as we've said before, it's as if both parties believe that transition will establish an ideal state that is free from conflict, pain, and confusion. But we are very concerned that this short-term solution in search of comfort is at the expense of serious long-term consequences and losses in that person's life. Our experience of working with patients who suffer from gender dysphoria is that they feel threatened by the idea that they have a mind that could register psychological meaning. Their fear means they try to close and flatten any exploration of their mind or the idea that their thoughts and actions are driven by internal motivations. This disavowal of meaning can produce an unhelpful impasse or frustrations between a therapist and the patient, as the therapist is continually trying to draw attention to meaning while the patient insists on actions and that the actions have no meaning. This is painstaking work, as anyone who's doing it will know. The therapist needs to find a way of commenting on the dynamic while understanding it is part of the person's defensive structure. Over time, and with the support of the therapy, different elements of the patient's mind that may have remained hidden or silent sometimes begin to find a voice. How am I doing? I've got the concluding paragraph. So whatever decisions are made regarding medical treatment, a thorough psychotherapeutic and psychiatric assessment is essential to be able to help these vulnerable young people, their families, and the clinical teams make informed decisions. I'm just going to miss that bit out. So throughout our careers in mental health, we have been familiar with similar types of clinical presentation: depressed patients feeling worthless and suicidal, anorexics who feel too fat and starve themselves, obsessional patients performing rituals repetitively before they can do anything else. We need to show both empathy and understanding of the mental defences whilst also making objective assessments of the patient's difficulties. And in our opinion, this must also apply to patients seeking gender transition, not in order to pathologise them, but in order to help them with their internal worlds. And I'll wrap it up there. We've got a bit more, but just to say that we would believe that that would benefit anyone who is considering a serious step in transitioning. We're not saying it's the only model, but we'd like to think it does contribute to trying to think and open up the ideas about what's happening with our young people in particular in this. So